look much better, but that's okay. So I'm going to go ahead and share my screen and make sure everyone can see my presentation, and then I'll get started.
Oh, let me.
Okay. Oops. Are you seeing this?
I am.
Okay, everyone looks like I've got some thumbs up, so good. Okay. Let's get started. And I'll go ahead and leave my face up so you can read my lips if that helps you. I like to shut my video off, but I won't do it this time. All right, so the title of my presentation is called Hearing Loss and Cognition. So I am Dr. Bree Nowd. I'm a clinical audiologist at the Center for Hearing and Speech. I attended the University of Central Missouri in Warrensburg. That was for my bachelor's in speech language pathology. And then I went to Washington University for my doctorate of audiology. So just a little bit about the center. We are a nonprofit. As of this year, we're actually 100 years old. We've been around since 1920. Some different services that we offer are audiology diagnostics, hearing aid services, auditory processing, cochlear implant services. Those are all related to hearing. We also have speech therapy. And then when the schools were open, I guess some of them are reopened, but we have a team that goes out and does vision and hearing screenings. And we also have a large box truck that we take to different big companies and do the testing as part of the OSHA standards. We mainly service the St. Louis Metro. And we offer a variety of financial assistance based on the individual needs of each client. And we also accept a variety of public and private insurance. So we're going to get started with the basics. Hearing is the process of sound traveling through the outer, the middle, and the inner ear. Although sound enters through the ear, it is actually interpreted by the brain. So what you're seeing here is a picture of the outer ear. This consists of the outer part that you can see, which is the pinna, which is this. This is your cartilage, the pinna, and then your ear canal, okay? Oops, sorry. The outer ear leads to the middle ear, which consists of the eardrum, and then we've got some tiny bones inside the middle ear, which we call ossicles. They're referred to as the malleus, the incus, and the stapes. So you can see those on the picture and see that they're blown up quite large because those bones are very, very tiny. That's a trivia question that everyone likes to use is where are the smallest bones found in your body? And it's your ear. It's not your fingers or your toes. So you'll get that question right next time. All right. The middle ear leads to this organ, which is the inner ear. It contains the snail-shaped cochlea and the hearing nerve. And the cochlea is what you see that looks like a snail, and the semicircular canals are what help us with balance. So it's all connected, your hearing and your balance organ. So how do we actually hear? I'm going to go through all of these numbers and tell you the process. So sound, number one, sound is transmitted as sound waves from the environment. They're gathered at the outer ear, and then they're sent down the ear canal to the eardrum. At number two, that kind of clear, or the, whoops, sorry. There we go. The kind of whitish part, that's your eardrum. So the number two is actually in the middle ear space. The sound waves cause the eardrum to vibrate, which sets those little tiny bones into motion. Okay, number 3, now we're in that little cochlea. The motion of the bones causes the fluid in the inner ear or the cochlea to move. Number 4, still in the cochlea, the movement of the inner ear fluid causes the hair cells in the cochlea to bend. This change in movement turns into electrical pulses. And then number 5, that's on the hearing nerve. The electrical pulses are transmitted to the hearing nerve, which then go up to the brain, and they are interpreted as sound. Each of these parts of the ear plays a critical role in transmitting sound. Your natural hearing depends on them working together, and if there's a problem anywhere along the process, you may experience some hearing loss. As hearing loss occurs, the hair cells in the cochlea begin to die, and we refer to those as dead regions. Once the hair cells die, they can't be regrown. So next we're going to talk about the types of hearing loss. The first type is conductive, and this is caused by something that stops sounds from getting through the outer and the middle ear. Sometimes this type of hearing loss can be treated with medicine or surgery. The next type of hearing loss is sensory neural. So this occurs when there's a problem in the way the inner ear or the hearing nerve works. This is a permanent hearing loss, and it's also the most common type of hearing loss. Most people who have what we refer to as age-related hearing loss have sensory neural loss. So I would say most of my patients over the age of 60 to 65 usually come in with at least a mild loss. Oops, I forgot the last one. The last one is the mixed loss, which includes both a conductive and a sensory neural component. So you can have a combination of two, which means that there's a problem in multiple spots of the ear. Okay, so we have different degrees of hearing loss. Sometimes you hear people throw out percentages. We don't really talk in percentages in regards to hearing loss. I think that's just more of a guess, but we say that you either have a mild, moderate, severe, or profound loss. So if you have a mild loss, you can hear some speech sounds, but soft sounds are going to be hard to hear. If you have a moderate loss, you may hear almost no speech when another person is talking at a normal level. If you have a severe loss, you will hear no speech when a person is talking at a normal level, and probably only some loud sounds. And if you have a profound hearing loss, you will probably not hear any speech, and you will only hear very, very loud sounds. So hearing loss can be described as many different ways. We have unilateral, which is just one ear, versus bilateral, which is both ears. Prelingual, which is a hearing loss that occurs before a child learns to talk, or postlingual, so after a child learns to talk. We've got symmetrical or asymmetrical hearing loss. Progressive, which means it gets worse over time, or sudden, which means it happens quickly and unexpectedly. Fluctuating hearing loss, it can get better or worse over time. That is not very common, and it's typically goes along with some other diseases of the ear. I'm sorry, it will get worse probably, but it doesn't usually get better. That usually comes with diseases of the ear. And then congenital means it was present at birth, or acquired, which means it occurs sometime later in life. So when you have a hearing evaluation, we test you multiple ways through air conduction, bone conduction, and word discrimination. When you're tested with air conduction, you listen to tones at different frequencies or pitch. And then we find the lowest volume of detection at each frequency tone. So if you've ever had your hearing tested before, we say, okay, listen for these beeps and push the button when you hear it, even if they're really soft. When we do air conduction testing, we're presenting the sound either through earbuds or with earphones over your ear. So this tests the entire hearing mechanism. It tests the outer, middle, and inner ear. With bone conduction, this is tested through a bone oscillator. We place behind the ear on the mastoid bone. You've got this hard bone back here, and it transfers sound directly into the inner ear. So we get to bypass the outer and the middle ear and put the sound directly to your hearing organ, okay? So doing these two different ways of testing helps us determine what type of hearing loss you have, if you have the sensory neural, the conductive, or mixed. And then we test for word discrimination as well. This tests your ability to understand words at a comfortable loudness level. And then you repeat them back to us. And at that point, we give you a percentage, but that's the percentage of words you repeated back correctly, not the percentage of loss that you might have. Okay. A little bit more about word discrimination. This test is used to give us some extra clinical information. So number one, does the patient's performance agree with his or her pure tone loss? Okay. Does it identify unusual asymmetry that is not predicted by the air or bone conduction audiometry? We also use it to monitor your performance over time. So if you start out getting 100% correct and you're able to repeat words back at a comfortable level, and then over a period of so many years, that percentage starts to go down, that's a way for us to counsel you on better listening and communication skills. And then we also use it to assist in making amplification decisions. So if you can only purchase one hearing aid, or you only want to purchase one hearing aid, that would help us determine which ear that we should aid. Okay, next we're going to talk about understanding the audiogram. So results from the hearing test are displayed on an audiogram, which is what you're seeing in front of you. At the top, we have the vertical lines, which are pitches like keys on the piano. So on the left side, we've got low pitch up to the very highest pitches on the right side. On the left side of the graph, with the horizontal lines, that is volume measured in decibels. So towards the top of the graph, that's a lower volume, and towards the bottom of the graph, that's a higher volume. So this graph is what shows the softest sounds a person can hear at different pitches or frequencies. Those symbols, the circles represent your right ear, and the X's represent your left ear. That's universal symbols for the audiogram. So where the symbols fall on the audiogram indicates your degree of hearing loss. So the closer the symbols are to the top of the graph, that means you have better hearing because you can hear the sounds at a much softer level. So if I were to explain this audiogram to the patient, I would tell them they start off in a moderate range in the low frequencies and then slope down to a severe range in the high frequencies. Because at 250, they're around 45 to 50, and they slope down to 60 and 65 at 8,000. So here's another graphic just to kind of show you the different degrees of hearing loss. So that kind of aqua color at the top, that's the normal hearing range. And then where it says slight, that actually we consider normal hearing range for an adult as well. If this was a child, they would consider normal range where it is there. So that underneath the normal and slight, that's where we start for adults. So we've got a mild loss, a moderate underneath, moderately severe, severe, and then profound. So like I said, the farther up on the graph that you are, the better your hearing thresholds are. Hearing loss is present in 20.3% of Americans aged 12 years and older. Generally, the prevalence of hearing loss increases with age, And then worldwide, about 360 million people report hearing loss. So that's just reported hearing loss. And that's about 5.3% of the world's population. So with the effects of hearing loss, our biggest concerns are speech intelligibility, so being able to understand what other people are saying. And then there's something that we call cognitive burden or cognitive load. And when you have a hearing loss, that tends to increase. So studies show that listeners with poor hearing also show reductions in memory for what they've heard. So when you have a hearing loss, you're trying to focus harder on listening to the person, and therefore you're taking resources from other parts of your brain and not really understanding what's being said, and also utilizing more resources than normal. And so it actually makes you, cognitively and physically tired sometimes. So we're going to go through a few points. Understanding spoken language, that is what we want as audiologists. We want you to best be able to understand spoken language, but it requires more than just your ability to hear. So to understand this, we can consider how the intended speech signal can become degraded within both the environment and within the listener. So there can be different factors that affect the quality of speech. In natural conditions, speech often occurs degraded because there's background noise or competing talkers or, anything else that might be around you. We're very, very rarely in just pure silence unless we're going to bed at night. So the first bullet point we're going to talk about in regards to the environment is background noise. So background noise can actually cause the ears of those with hearing impairments to work differently than those without hearing impairments. When you're in noise, the neurons and the hair cells in your inner ear are working really, really hard because they're spread too thin. So earlier when I discussed those dead regions, that's what this is talking about. There's now some dead regions where you don't have those hair cells to work for you anymore. So now you've just got a few and they've got to cover more ground than they usually do. So this is comparable to turning on multiple television screens, we'll say 12, and asking someone to focus on one specific program. So you may be able to get some of the information, but naturally you're going to get distracted by all of the other programs and you're going to lose attention and probably not be able to recall everything that was on the one program we asked you to listen to. There is essentially no change, even for those with hearing loss, in terms of how the cochlear neurons are processing in quiet surroundings. Okay, so with hearing loss or with normal hearing, when we're in quiet settings, we don't really notice that much of a difference. But once you add noise, that makes a big difference. Okay, it's already hard for someone with normal hearing to hear someone in a noisy restaurant, but for someone with hearing loss, it's even more difficult. So the auditory system in the inner ear filters sound into a number of channels that are tuned to different frequencies. In a normal system, those channels are sharp and focused. They know exactly where they're going to and what to listen to. But once we have those dead regions, they get broader and more scattered. The next point in regards to the environment is the stimuli. So when listeners hear speech, you have to match the rapid incoming acoustic stream to stored representations of words that are in your brain to be able to actually extract the intended meaning. So the process of correctly identifying sounds is made more difficult when the speech is acoustically degraded. So you've got less information available to you as a hearing impaired listener, which reduces the quality of the speech cues and then increases the chance for error. Okay. The third point in regards to the environment is lexical effects. So what that means is this is how common a word is in the English language, or how similar a word sounds to other words. That can actually affect your ability to understand speech. So in the context of lexical competitions, words with a large number of competing targets, like cat, sounds like cap, sounds like cab, or words that are less dense. So that means words that are rarely used in speech. Those are more difficult to accurately perceive. And additionally, context can affect a hearing impaired person's ability to understand speech. So if you're sitting around and you're talking about the baseball game last night and you carry on talking about the baseball game, a person with hearing loss can generally kind of pick up on the whole conversation because they're filling in any missed words with context clues. But if you've got someone talking about baseball and then someone changes the subject and asks, "What'd you have for dinner last night?" You're not quite ready for that subject change, and you may actually miss what they're trying to say, and then that creates some confusion and sometimes some animosity. It's also, context can also have to do with getting someone's attention first. So if you come up behind someone and start talking to them, if they have a hearing loss, they may not realize that you're talking to them. But if you get their attention first, tap them on the shoulder or say, "Hey, Bree," and then I turn around and say, "Yes," well, there's my context, and I know someone's about to talk to me, so I'm ready to listen. Now we're going to talk about some factors in regards to the listener themselves. So even when words are spoken with adequate volume and clarity, the person's hearing loss can have an effect on the speech. So a lot of times I will hear people say, everyone around me mumbles. Well, a few people might mumble, but not everyone does. That's just the effect of the hearing loss that you have, making things sound garbled and mumbled and like people are talking really softly. And so the severity of your hearing loss, older people with moderate to severe hearing impairment had a 29 to 57% greater risk of cognitive impairment than those with normal hearing. In a recent study compared to those with normal hearing, individuals with hearing loss had a 24% increased risk of cognitive impairment. Rates of cognitive decline and the risk of incident cognitive impairment are linearly associated with the severity of an individual's baseline hearing loss. And we'll talk a little bit more about why that may be. Another factor is the configuration of your hearing loss. In addition to people reporting others mumbling, the other biggest complaint that I hear is that people say, I can hear that people are talking, I just don't always understand what they're saying. And that has everything to do with the configuration of your hearing loss. So a lot of people with hearing loss, especially with age-related hearing loss, have this type of configuration that you're seeing on the screen. The lower frequencies, from 250 to 1000, those are maybe in the normal to mild range. And then their mid to high frequencies kind of slope down more into the moderate to severe range. In the low frequencies, that's where male voices are at, as well as the vowels in speech. Vowel sounds are very loud, and so that's what gives us the volume. As we go into the higher frequencies, that's where children's voices, women's voices, and then consonants are in the high frequencies. And so consonants are what give us clarity. So that's why, you can hear that people are saying a word, but you're not sure if they're saying dish or fish, okay? Because you're lacking the clarity because you're not getting those consonants from the hearing loss. The other factor related to the listener is, of course, age. The brain has to compensate for the lack of auditory input, and these cognitive processes are particularly difficult for older listeners. So the normal aging process is associated with declines in certain cognitive abilities, such as processing speed, certain memory, language, visuospatial, and executive function abilities. When you age, your brain faces significant changes. One study found that as older adults listen to spoken sentences, their brains use many of the same regions as younger adults. So that part is good. However, they've been shown to use more parts of their brain than what younger adults do. So this may be a sign of increased listening effort or cognitive burden, like we were talking about, that's needed to fully understand spoken language. There is a significant variability in age-related cognitive changes from individual to individual. Some of that variability can be attributed to genetic differences, and studies estimate about 60% is what can be attributed to genetics. Medical illness, psychological factors, and other sensory deficits such as vision loss can also accelerate age-related cognitive decline. So participating in certain activities, keeping your body healthy and active, your brain active by, playing card games, doing any type of word searches, watching Jeopardy, all that stuff is going to keep your brain nice and active. So, what does a combination of background noise, unclear stimuli, lexical effects, severity, configuration of hearing loss, and age lead to? All of these factors may cause frustration or mental exhaustion, which may even eventually cause a person to become more isolated and begin to avoid social settings. We refer to this exhaustion as listening effort or listening fatigue. So this is a little more about listening effort. To maintain optimal understanding, listeners with hearing loss must allocate more cognitive resources or brain power to listening than do listeners that do not have hearing loss. Cognitive resources are not unlimited, so using additional parts of your brain to listen leaves fewer resources available for other tasks. So for example, to maintain optimal understanding in a challenging situation, like maybe in a noisy restaurant, persons with hearing loss may need to shift more resources from other ongoing cognitive tasks, like visual processing or memory, than individuals without hearing loss, which can impact the ease of communication. When hearing loss is present, the brain has to compensate for that loss and work harder than before to process the same information, which causes stress on the brain and fatigue. So, how can we combat cognition in association with hearing loss? The answer is quite complicated. They're doing a lot of research all of the time on this topic, but we can't as of yet. There's nothing that's been figured out. So correlation does not equal causation. There's no definitive proof that hearing loss causes dementia or cognitive decline, or even that it speeds up the rate of either. There are, however, many studies that show some sort of link between untreated hearing loss and cognitive decline. So we say it correlates, but it's not necessarily something that causes the other. Okay, I'm going to go into a few research studies just to give you an idea of the literature. A long-term study of 2,040 older adults found that cognitive decline was significantly reduced in subjects who used hearing aids. Subjects were age 50 and older. They had no dementia at baseline, and they began using hearing aids during the 18-year period. Cognitive function was assessed using short-term and delayed recall of a list of 10 words. So that means they tested them by giving them 10 words and asking them to recall it right away, and then maybe doing another task for 5 or 10 minutes, and then asking them to recall the words again. Before using hearing aids, participants could remember 0.1 fewer words on the memory test per year on average. Following hearing aid use, the average rate of decline was reduced to 0.02 fewer words recalled per year. That doesn't seem like a lot, but in the statistical world, that's a lot. That's what we call a statistically significant study. This suggests that effective identification and treatment of age-related hearing impairment may have a significant impact on age-associated cognitive trajectories and possibly reduce the incidence of dementia. A little bit about dementia. It's a major global health problem. A study completed in 2018 suggested that treating risk factors could prevent or minimize 35% of dementia cases. It also found the strongest of the treatable factors is untreated hearing loss. On average, respondents in this study began using hearing aids at age 62. After controlling for covariates such as age, gender, physical activity, and smoking, these results indicated that episodic memory declined with age, but the rate of decline slowed significantly after beginning the use of hearing aids. Some other effects of untreated hearing loss may be depression, anxiety, frustration, social isolation, or fatigue. This study done in 2018 attributed the negative effects of untreated hearing loss on cognition to 2 possible cases or causes. Number 1, both hearing loss and dementia are caused by age-related decline in the central nervous system. Or number 2, the decline is due to auditory deprivation, which means that your auditory nerve is not being stimulated. That would be someone without hearing aids and with a hearing loss. And the resulting reduced social engagement and increased depression and anxiety. They argued that their findings supported the latter explanation and suggest increased access to quality hearing healthcare might delay the onset of cognitive impairment and help reduce the impending dementia epidemic. These are a few studies done by some colleagues of mine at WashU. Understanding the effects of hearing loss on cognition and language perception is important for advocating for healthy hearing. Kuritzer and colleagues, she was actually a student in the audiology program a few years ahead of me. She found that sentence memory was poor when the sentences were degraded with noise. So degradation can occur even when the speech is intelligible and semantic contextual clues are provided when a hearing loss is present. So even if I am speaking loud and clear and I'm enunciating, if there's noise in the background and you have a hearing loss, it doesn't matter what I do, you're still gonna have a difficult time hearing. Peel was actually my mentor in grad school, and Wingfield was his mentor when he was in grad school. They did a study together in 2016 and found that even mild levels of hearing loss can lead to structural cortical changes. So they were finding, he does a lot of fMRI scans, and they were finding that even when there's mild hearing losses, the gray matter in your brain actually can reorganize itself. These findings suggest the necessity for early amplification so that we can access as many sounds as possible. The cognitive effects of hearing loss may be countered with the use of hearing aids, making it easier for a person to hear and understand what's being said. Therefore, a person's cognitive resources will be used more appropriately, expending less listening effort, and then decreasing the rate of cognitive decline. And just a few more studies. This study done in 2015 examined the relationship between hearing loss, hearing aid use, and cognitive decline. So this study followed 3,670 randomly selected older adults over a 25-year period. 1,276 participants self-reported hearing loss, and the other 2,394 reported that they had no hearing loss. The population was divided into 3 groups. Number 1, no hearing loss. Group 2 was hearing loss with no hearing aid use. And number 3 was hearing loss with hearing aid use. The subjects were seen about every 2 years over the 25-year period, and they did neuropsychological evaluations of cognitive performance, cognitive complaints, and functional ability. At baseline, all of those reporting hearing loss had significantly lower scores on scales of global cognitive performance compared to the group reporting normal hearing. So any of the cognitive tasks they did, it was reported that most people with hearing loss did significantly poorer than those without hearing loss. At the 25-year follow-up, the subjects that were not using hearing aids declined more rapidly on cognitive performance measurements than those who did use hearing aids. Furthermore, subjects with hearing loss who used hearing aids had no significant difference in cognitive decline from the control group, which was the group with normal hearing. Although this long-term study found that adults who used hearing aids did not experience the cognitive decline associated with untreated hearing loss, this was not a randomized controlled trial. It may be that adults who choose to use hearing aids differ in other ways from those who choose not to, i.e., financial reasons. That's obviously a big reason that most people do not use hearing aids. And then the last study was done in 2011. This was a very small study. It investigated hearing aid use and cognition. 12 adults were divided into 3 subgroups, pretty much the same subgroups as before: normal hearing, hearing aid use, and no hearing aid use. The group with hearing loss without hearing aid use showed the lowest scores on an intelligence test, while there were no differences, once again, between the normal hearing and the hearing loss with hearing aid use groups. But of course, to be noted, this was a very, very small study. So that is all I have for you today. I'm going to leave my phone number. This is the number for our main office. And then I have my email as well. So if you have any further questions, you can email me. Like I kind of said in the beginning, the Center for Hearing and Speech offers financial assistance. So if that's something you're wanting to look into, go ahead and give us a call and we'll point you in the right direction. And that's all I have.
Dr. Nowd, thank you so much. That was really interesting. If anyone has any questions they wanted to ask Dr. Nowd, feel free to type them in the chat box here. We'll keep it up for just another minute or two. But I actually do have a question for you.
Okay.
So if you are someone who does have severe hearing loss and you wear hearing aids, do you recommend like headphones if you want to listen to something, say somebody else is not watching? So you want to listen to something on your phone or read an audiobook? Do you recommend headphones for someone with hearing aid?
Do you mean just because you think it would be louder or so that other people are not hearing it like just because you have something in your ears, you pop something else in? Is that what you're asking?
More so that nobody else can hear what you're listening to. Yeah.
Okay. That would be an option, but actually all of the new hearing aids now have Bluetooth compatibility. And yeah, most of them will work with, actually all of them will work with Apple, and then some of them will work with Android. So when people come in, that's usually the first question I ask is, what type of cell phone do you have? Because that kind of points me in the direction of which manufacturer to purchase. So that usually eliminates the need for any kind of headphones, because then it's just streaming straight to your ears.
Oh, that is fantastic.
Yeah.
Thank you. Does anybody else have any questions for Dr. Nowd before we sign off? Oh, yeah.
Okay.
Can
Yes.
you?
We have a Sennheiser. I've forgotten the digital part of the number, but it is a set of headsets that are designed for people with mild to moderate hearing loss. And within that, you can choose whether you get compression, high frequency pre-emphasis, or none of the above. And they were suggested to my wife, who uses them a good deal of the time. And what's interesting to me as an outside observer is that she can't tell from hearing which of the modes of operation has been selected. If she picks them up and puts them on, she can hear whether there's high frequency or compression or just amplification.
Mm-hmm.
And I just find that very interesting, but it's also a very interesting tool.
Yeah. So are those supposed to be like amplifiers, or? Or is it something specifically that you're using when you're watching TV? You're on mute. Hold on, Steve. There you
So
go.
I was muted.
Go ahead.
It is designed for TV. In fact, the Sennheiser model number says something like set TV as part of its model number.
Okay.
And like I say, it has 4 different modes of operation: nothing, amplification, compression, and equalization.
Yeah.
And it's interesting to me as an outside observer by about 3 feet,
Yeah.
that most of the time she can't tell which one it is using, and doesn't necessarily select the mode that she wants that evening.
Okay.
But nonetheless, it works.
Okay. Yeah, I was wondering because the Sennheisers that I know about are the TV connectors, and they just have the little buds that kind of looks like a wishbone. And you just, yeah, and it just sends a ray from the TV. So, I mean, it has to do with the technology inside of the device. Inside the Sennheiser, it probably costs, a couple $100, I'm going to guess, but it's not going to have advanced technology by any means. Hearing aids now have the equivalent of 3 computers inside of the little tiny device. So they are very, very smart devices, and they make a decision every single nanosecond, essentially, as to where you are, what you're hearing, if it's speech, if it's noise, and then it uses its algorithms to decide what it should sound like.
How
So
does that compare to cochlear implants?
So cochlear implants are a completely different type of device, and implants really are used when we get to a point that hearing aids are no longer an option, because this gets a little bit more into the science of it, but those dead regions I was discussing, if you get to the point where you have pretty much all dead regions and you have no hair cells, it doesn't matter if we put a hearing aid on you, you're not going to hear anything because there's no hair to deflect, the fluid doesn't move anything. You don't get any sound. But with an implant, there's a little tiny electrode array, like that big, that gets coiled into your cochlea, and it produces electrical stimulations to mimic what the hair cells would have done previously. So it's a completely different type of device, and it's obviously a surgical procedure, but it's created for people who do not get benefit from aids anymore. It's a medical device that insurance typically will pay for. So we have to do implant evaluations to prove to your insurance that you qualify. And that also includes doing a hearing aid trial. So anyone who's going to get an implant, you know, has to try hearing aids first, basically just to see if those are usable. Does that answer your question?
Yes, thank you.
Okay.
Dr. Nowd, did you see in the chat box, can you talk
Yes.
about hereditary hearing loss that shows up in early adulthood?
Yeah. Okay, so you're referring to cookie bite hearing loss. That's kind of funny because that's often what we refer to a configuration that might look like this. So in the low frequencies and the high frequencies, you're up towards the normal to mild range. And in the mid frequencies is where it drops down. That's what we call a cookie bite. And that's typically seen with hereditary or just genetic hearing losses in general. Let me talk about what are the warning signs. I would say the warning signs are just you struggling to functionally communicate. So when people come into me, if they come in and they say, I am really struggling, I can't hear what people are saying, I can't understand, you know, I have to work, I have to do this, I have to do that, and I'm having a hard time. That's a big warning sign. When you can no longer functionally communicate as you used to be able to, that's a good time to come in. Anything you can do to reduce the severity, really, I mean, protecting your hearing if you're going to be around anything that's loud and noisy. There's no proof necessarily that wearing hearing aids will not make your hearing worse, but there are studies to show that keeping stimulation to your nerve, to your auditory nerve, keeps it exercised, just like we keep our bodies exercised, and that helps us do better with hearing aids. So like if you come to me with a very mild loss and get hearing aids, and maybe over time your hearing gets worse and worse, you're going to adapt to that better than someone who waits until their hearing is severe and comes in for the first time. You're going to have a lot harder time adapting to hearing aids and, you know, being able to hear as well. So hopefully I answered your question, Dominique. If you have any more, you can type it into the chat.
Yes. So thank you for answering that. I'm at the very, I guess, genetic or hereditary hearing loss runs in my family. And right now, just cookie bite, it's in the mild range at the very lowest. So when would you recommend that someone would actually get a hearing aid?
Well, that depends on many factors. If, you know, finances had nothing to do with anything and, you know, hearing aids were free, I would say right away. As soon as you have a hearing loss, I would get hearing aids right away. Unfortunately, they're very expensive, which is why we offer financial assistance, because we kind of fill in the gaps for the people who can't afford hearing aids. So it kind of comes down to the cost benefit. If you, let's say, just don't qualify for financial assistance because you make too much money, I would say, you know, when you're ready, you'll know, because you'll be struggling a lot and you'll get to the point where, you know, you can't handle it anymore. But if you're going to pay full price for hearing aids and you have a very, very mild loss, you may not notice enough of a difference to say, oh, I just spent a couple thousand on these, you know, and I'm not really noticing a big difference. But if you're going to come to us and you do qualify for our financial assistance, and it's going to be very, very cheap, then I'm always going to say, let's do it. Let's do it as early as possible. So I hope that is good for you as well.
Yes, thank you.
Mm-hmm. So Dominique, if you're interested in getting your hearing tested, or at least, you know, seeing if you qualify for our financial assistance, anyone can apply. So you can just call the number I had at the end of my slides, and I can type that into the chat so you can see it. And we can get you set up at least to get a test done.
Is ringing in the ear a sign of hearing loss? Lynn wants to know.
Okay, Lynn. It can be. It's not always associated with hearing loss, but oftentimes that's one of the first things that people notice is that ringing. It's what we call tinnitus. That's the scientific clinical name for it, I guess. And they do a lot of research on it, but we still can't really figure out where it's coming from along the pathway. We don't know if it's in your cochlea, in the hearing organ. We don't know if it's on the nerve. We don't know if it comes from the brain. So that's more of the problem, is not knowing where it stems from. But a lot of times when people have ringing in their ears, if they wear a hearing aid, that actually diminishes that sound while they're wearing the hearing aid, because it's an internal sound. And when you mask over that internal sound with external sounds with the aid, it's usually enough that it brings it down and you don't notice it while you're wearing the hearing aid.
That is interesting.
Yep. Any other questions, either through the microphone or in the chat? I put our phone number in the chat, so if you want to call us and talk about financial assistance, or if you want to come in and just look at hearing aids, we don't only see people who are financially assisted. We see anyone and everyone who wants to come. So, and you can also, oh, go ahead.
I was just going to ask another question just about like requesting either like accommodations or either, especially receiving medical care. If someone like reads lips right now, like what, if you have hearing loss, what types of accommodations can you request and legally people are supposed to provide?
Do you just mean in general?
Yeah.
Or first? Okay. You're allowed to ask for captioners, interpreters, if you sign. The problem with the masks right now is that a lot of people read lips without realizing they read lips. So if you have any hearing loss, I guarantee you read lips to a certain extent, even if you don't notice you do it, because the visual cues help fill in what you're missing from your ears. So the masks do make it very difficult. When I am at work, I actually wear a mask that has a clear part here so that people can still read my lips while I'm providing services. The other thing I've told people is, if you're out at the store, if you're anywhere that a mask is required and there's some kind of barrier, if they have plexiglass or anything and you're struggling, you might just ask the worker if they mind, pulling down their mask for a moment so you can read their lips. If you explain to them why you need it, and as long as they feel safe doing it, if there's, some other type of barrier there, or even if you can just, if there's no barrier, but you can step back while they pull down their mask, whatever is comfortable with you and the other person, that might help as well. But I find that just explaining things to people and advocating for yourself is really just the best route to go.
Thank you.
Yep. And I put my email in the chat as well. So if you think of questions after this, feel free to email me.
Fantastic. Dr. Nowd, thank you so much.
You're
Everybody,
welcome.
thank you for coming today. I appreciate
Thank you for the silent clap, Steve.
Thank you so much. I'm going to take just a moment to thank everyone again and let everybody know that this was recorded. And as soon as I have the recorded link available, I will send it out to everyone.
Awesome.
And I wish everybody a great day. Come back and see us again in January for the next one.
All right. Thank you.
Thanks, Dr. Nowd. Bye, everyone.